What is going to follow is quite sobering. Deaths from CVD surged 60% globally over the last 30 years, reaching a daunting 20 million in 2021. 4 out of 5 of these deaths occur in low and middle income countries. The World Heart Report, the first ever World Heart Report that we're going to launch today, assesses cardiovascular health globally and provides the foundation for advocacy, raising awareness, reinforcing political commitment, and promoting global action. It shows that countries that invest more in healthcare as a percentage of gross domestic product have lower CVD rates, while CVD rates are higher in countries where people pay more out of pocket for healthcare. I will stop here and I will let our fantastic journalist, Jackie, introduce the panelists and start this conversation. Jackie, over to you.
Thanks very much, Boriana. I think we've heard already this morning the importance of data, and this report is an excellent source of information. It has information that shows us we are making some fantastic progress, but there are some worrying trends. And our speakers in this session today will give you some important data on that. Just to highlight, it shows that cardiovascular disease-related deaths have nearly doubled in 30 years, reaching 20.5 million in 2021. That's up from 12 million recorded in 1990. And this new figure represents around 1/3 of all global deaths, higher than the cancer mortality. So we are talking, this is serious, serious business. As Boriana says, we want this report to drive awareness, drive advocacy, and drive change, and hope that the media take this on board, and position, of course, the World Heart Federation as a global thought leader. It's available on the Summit app, so please do have an in-depth look later on. But I'd like to introduce now our 3 speakers. First of all, Fausto Pinto, as you know, past president, professor of cardiology at the Hospital of Santa Maria, who is going to give us an overview of the report, followed by Mariachiara di Cesare, who's professor of population studies and global health at the Institute of Public Health and Wellbeing at the University of Essex in the UK. And also delighted to welcome Kiril Karamfiloff, who is president-elect of the Bulgarian Society of Cardiology and professor of cardiovascular health at the University Hospital in Sofia in Bulgaria. So thank you very much. There will be time for questions and answers at the end of the 3 presentations. And I'd like to invite Fausto to take the podium.
Well, thank you so much, Jackie. Good afternoon, ladies and gentlemen. I hope you had a nice lunch. The afternoon session after lunch is always a little bit concerning, but I hope we can keep you alert with this fantastic new initiative of the World Heart Federation, which actually is embodied in one initiative that we launched 1 year ago, the World Heart Observatory. And this is the deliverable, is the product 1 year after the World Heart Report that was, as was mentioned, it is the first World Heart Report. It provides a lot of information. As the first, of course, there will always be room for improvement, to be expanded, to be also, in a way, having all the feedback that we would like to have from all our members, because this World Heart Report is to be used, is to be useful. We want it to be meaningful. We know there are hundreds, thousands of data sources, of data registries, of many societies, foundations, organizations, they organize their own data. But we felt, and that was the whole rationale behind the creation of the observatory, we felt the need to have a global platform where, with our members, with our partners, we could collect the data, collate the data basically, and be able then to digest that data. Data is knowledge, knowledge is power, and the only way, and we saw this morning, the only way that we can have to change is to know the reality, and the reality is based on data. And that was the whole rationale behind the creation of this observatory. the organization of the World Heart Report. And here I have to thank the team that was behind it, with Mariachiara, that will present you a little bit more in detail in just a few minutes. Some of the highlights of this report, Pablo Perel, Sean Taylor, and the whole team at the World Heart Federation that produced the report. I also want, of course, to thank the providers of data, and we will give you a little bit more detail on that, particularly the GBD group, but also the NCD Countdown, WHO, the World Bank, and we very much appreciate that effort. And again, this is also a teaser to all our members to contribute to this World Heart Report, because as you will see, it will be very relevant that all of us use it for advocacy, use it to increase the awareness of the problem that we are dealing with. Unfortunately, we have the gold medal here. It's a gold medal that I would like not to wear, to be the #1 killer in the world. This is not nice, but we want to ensure that we can do our best all together to provide tools that can help us to address the problem of cardiovascular disease, to promote cardiovascular health. I think that's one of the primordial messages that we've heard this morning. It's much better to prevent than to treat. So prevention here is a key feature, and we can only do that if we know the data. The other important element of this World Heart Report, by providing that data, is actually the ability that in each region, in each country, to have that data that can be used for the decision makers. We heard today many ministers here and how relevant it is that we can provide that sort of information, that sort of data, the benchmarking that can be done between countries, between regions, continents, and with that being able to convey messages that can, on one hand, highlight even further the problem, but also to find solutions that can help us to mitigate the problems that we are faced with. And we can only do that if we do have the data, and that's what we are trying to do with this World Heart Report. We are also launching some new parameters, and there is a new index, which is the WHF Policy Index, which we believe can be very relevant. With our advocacy committee, we identified 9 different parameters, basically initiatives that we can assess objectively if they are or not implemented in the different countries. And we created this index, which basically will give, and you will see that in the report, will give an idea in terms of how many countries are actually fulfilling all these different parameters, all these different initiatives, like, for instance, tobacco policies or having a cardiovascular plan for the country. And it was actually very appalling to see that, for instance, from the 166 countries that we have data information, only 64% have 7 or more policies that have been implemented in the countries. And if we go to some regions, like for instance the sub-Saharan region, only 13%, 1/3, actually have these 7 or 8 policies towards reduction, addressing risk factors and reduction of the burden of cardiovascular disease or promoting cardiovascular health. And this is just a teaser on some of the elements that you will find in this World Heart Report. But without further ado, I would like to introduce again Mariachiara, that has really been instrumental in the organization of this World Heart Report. She has just a couple of slides that will illustrate some of the elements, also a little bit how it's been displayed, and will give you, I would say, an extra teaser so you can actually have even more appetite to go back to the report and get the information that I'm sure it will be useful to you, and therefore it will be useful to our community. So I hand over to you, Mariachiara.
Thank you, and for the extra time, because I didn't know how to change slides otherwise. So good afternoon, everyone, and thank you for, I agree with Fausto. I hope that we can make you awake and not fall asleep after lunch with the World Heart Report launch. So my name is Mariachiara di Cesare. I'm a professor in population studies and global health at University of Essex, and have been working very closely with my team at Essex and the World Heart Federation team to produce this report. And I would like in particular to thank Sean Taylor for the work that he has put in this past months on the report. So as Fausto said, we wanted to create this first ever World Heart Report, and we want really be sure that this can be used and is useful. So it's really at the moment the first steps that we are doing to produce something that we hope is useful, and your feedback are absolutely essential because we think this can be a co-production work in the future. The data that have been used, I promised that I was not going to look at that screen, but at the one there, is the global burden of disease for mortality and some of the risk factors, the NCD risk for risk factor, metabolic risk factors, and the NCD countdown for premature mortality, and WHO data for policy and health expenditure and World Bank. Now, this is the first effort that has been done to essentially collate and bring together all these data sources. I don't know how familiar you are with one or the other, but really put all those data sources in one place in a way that you don't need to go in different places to find that information. So just to take from some of the points that Fausto has raised before, this is the regional trends in age standardized cardiovascular disease between 1990 and 2019. And one of the first things that we have tried to do is to show the regional differences, because we know that the age standardized cardiovascular death rate has declined over time, which is a great success. But we also know that the number of deaths has been increasing dramatically because of the aging and growing population. In this case, I'll just would like you to focus on the female. I hope that is on this side. Yes, on the female figure. Oh, thank you so much. On the female side, and what we want to just highlight, for example, is that each line represents a different region that is listed on your right. That's for female by 2019. Only Latin America had reached the level that high-income countries had back in 1990. So if you see all the other regions in 2019 still have a CVD, age-standardized CVD rate that is higher than the levels that we observed in high-income countries back in 1990. So clearly there is not, we were talking about equity in CVD, in cardiovascular diseases, in cardiovascular health. So we really think this is really important to be highlighted. And this is part of the report. It's just a bit, and then you go to the report and you can read more. The other thing is just whether there are any inequalities and differences. So one of the myths is that males have higher CVD mortality than women. But when we look at the comparison, so this example shows you the difference between men and women CVD death rates in sub-Saharan Africa, and the countries are ordered by the difference between male and female. So what you see here is essentially that 13 countries in the sub-Saharan region have a higher mortality among women than men. And this is happening in other regions. So, I mean, is something that is very important to highlight, and sometimes in our communication, we forget to present. It was mentioned by Boriana and Fausto that the association between out-of-pocket expenditure as percentage of overall expenditure and cardiovascular disease mortality. And what we see is that there is a positive association. So that means that the higher is the out-of-pocket expenditure as percentage of the overall health expenditure, and the higher is the cardiovascular disease mortality. So this is really important, especially if we think about universal health care. And then the index that Pablo was mentioning. So just to give you an idea about, Fausto mentioned few policy. We go from national tobacco control we have 8 to availability of CVD drugs in the public health sector. And this is showing you, each bar is showing you the percentage of countries that have, I cannot see the entire figure, so I need to tip it on, is the red is none is implemented to dark blue, all 8 implemented. And I think that Fausto very rightly highlighted, for example, if you look at sub-Saharan Africa, at the bottom, what you see is that, in fact, you have only 10% of the country that implements the 8 policies that have been identified as key and critical for cardiovascular health. And essentially 65% of the country have 6 or less of those policies implemented. So what you can see here is the variation across country. That is really what we were trying to highlight. In terms of key recommendations, so that then I can give the floor to others. We use the data. We use data from, as you know, GBD, NCD risk, NCD countdown. These are model data. And the model data, unfortunately, hide the fact that behind some regions, some countries may have more data than others. So we cannot forget that just because we have a nice line and a nice trend. And we really think that we need to improve data for cardiovascular diseases, especially where gap exists. So for example, low middle income countries, or for some group of the population. Ensure that health expenditure as percentage of GDP is at least 5% of GDP, as the recommendation from WHO. We think that we need to implement policies that, that combat essentially cardiovascular disease based on the burden specific of the country and the burden of mortality and risk factor. And we really need to be sure that those are implemented and monitored, and this is why the data are so important. We think that we really need to minimize the out-of-pocket if we don't want that positive association that we have seen. So it's really important that we prioritize this and we had our policymakers here. So I hope that this is a takeaway message for them. And the other is that we really need to find a way to address inequities and uneven progress in CVD. We have seen in the first slide across region, and that is a very macro level. But then when you go in a country and you go within the country, you have pockets of progress that's, I mean, is completely different from others. So we think these were our 5 key recommendations, and I let it here, and I hope that the reading of the report, you can enjoy it. Thank you. Thank you.
Thanks very much indeed, Mariachiara. Carol, would you like to make some remarks about the Southeast Europe?
Yeah, congratulations. It's really a nice document which really gives some information of what's going on for cardiovascular health in the world. But I'm here to give some example, not the best one, of how is the situation in the Southeastern Europe. Southeastern Europe, as you may notice on the information that you showed, has highest level of mortality from cardiovascular causes. And of course, I'm coming from Bulgaria. I'm an interventional cardiologist. I'm head of the Department of Cardiology and president-elect of Bulgarian Society, which gives me access to all kind of information, so I can present you in a very quick manner what are the real problems. So just quick fact that the average Bulgarian male lives 11 years less than average European male. This really highlights the deep problem that really needs some more intervention, some more information to be resolved. We have poor demography. 1/4 of the population is above the 65 years, and really around 15% are less than 14 years. So the active population is very low percentage. And we have a low birth rate, and as well as we have high mortality rate. So just quick fact that for last year, we have 120,000 dead people, more than 60–65% from cardiovascular reasons. The roots of that problem are really deep. They become evident during early childhood. We have top #1 reason for smoking among young persons. We have a high level of obesity and alcohol abuse, as well as this is one of the most important factors that leads to the fact that we have cardiovascular mortality in childhood as twice as European average. So coming from children which are not able to create a healthy lifestyle, and they are not really focused on what's going on to be healthy persons, coming to the healthcare system, which have really a lot of issues. We have no dedicated effective program of prevention. And the money, the resources are going directly to the tertiary help, I mean to the hospital help. And it's really something that we really need to change. We, as Cardiology Society, are aware of all that facts and are in permanent efforts to change it through a lot of PR actions in terms of measurement of blood pressure, days without salt, you know, being active, etc., etc. But we need to have really more potent communication with the government, because we could do really miracles in the cath lab, in the operation theater, but dealing with such high mortality, we need to do it at non-population level. And such kind of dedicated program is really necessary. So that are some of the really key facts I want to share with you, like the situation and the highest cardiovascular mortality in Europe.
So next year we'll invite the Ministry of Health of Bulgaria to be here with us.
Oh, that will be great, because I was a little bit jealous standing there and listening to the podium of ministers, the people that are really keen on doing something in favor of health. Unfortunately, they are changing quite a lot in Bulgaria, and you need really to have perspective for 10, 15 years to build such kind of program and to measure effects. And whenever you have front of influence like year and a half, it's not possible.
I think that's common with many countries where that turnover is quite quick, and as you say, very, very difficult to get momentum over the long term on cardiovascular diseases.
Yeah, but for us it's really important, because you see the rates. It's really, in other countries they're changing, but they're doing during being there good work. So
look, we've got some time for questions, so please do come up to the microphone if you have a question for any of our panel. Let me kick off by asking Mariachiara. For me, those figures on 13 countries in sub-Saharan Africa where women make up most deaths, higher than men, is that something that, you know, even you as an expert were surprised by, or was that something that was on your wavelength? Why is it that that's happening?
Yeah, so I think we were. I mean, we were impressed how many countries, and the majority are from the west side of Africa. So we were impressed, and the reason I think that is in a lot of the, I mean, from the early diagnosis to management to recognize the symptom and behavioral. So it can be a very complex, and I'm sure that colleagues from the region are able to justify and explain and looking. And we hope that is an information that can help them to look into the data in more details with the context and cultural context and regional context.
Sure.
But this is actually one of the reasons for the World Health Report, providing this type of information that can actually go into some of the misconceptions. There's a misconception that heart disease is less prevalent in women or less serious in women than men. And we know that that's not the case. And this is a very good example on how to use the data that can actually help you to promote policies and to have that sort of data that can help you also to get rid of some of the misconceptions that still exist regarding cardiovascular health.
Yes, absolutely. Thanks, Fausto. Okay, we've got some questions from the floor. Yes, sir.
Thank you very much. Kenneth Connell, Healthy Caribbean Coalition, located in beautiful Barbados. So I was quite struck at the recommendation slide. The first point that you made was continue effort to improve data of cardiovascular diseases, particularly where data gaps exist in low to middle income countries. I'm from a low to middle income country. Part of the challenges there would be the acquisition of data, the absence of electronic medical records, the whole data culture not quite being there. How does the international community kind of assist with that gap?
Well, I can actually provide the first answer. This is also one of the purposes of international, having a World Health Report provides you some sort of international backup, if you will, to help you also promoting that. And by the way, you had your Ministry of Health here today, so maybe still sitting here. So it actually can help you to promote that with your decision makers and show how relevant it is to improve the way you can collect data, you can have that data, and how relevant it is not only to know your reality, but also compare it with your other countries, either in the region or other regions of the globe, and therefore to provide you with that sort of information that can help you to grow to improve the way you can develop tools to collect, but also to use that data to have proper policies.
Fausto House, Sarasota, Florida. You mentioned about female have the higher mortality. Have you tried to look in your data premenopausal versus postmenopausal? The reason I'm asking that, because we have published data. Once female get in menopause, they have cardiodiposity. And those with the cardiodiposity have the higher problem than those without cardiodiposity in menopause. That's the question to you. To you about males in Bulgaria, 11 years younger, what about the females? Are they killing the males or what?
Actually, the males live 11 years less and females 8 years less. So this is the situation. Less the average European citizen, I mean.
Okay, who wants to take?
So just very briefly, that is a very good point. The report for this year was just focusing on the not age-specific analysis, but it's definitely something that can be considered for the future reports, because we absolutely agree that there are different ages differences and sex differences that should be taken into account.
Thank you. Gentleman at the back, first of all in the blue jacket.
Yeah, hi to everyone. I'm Elvis Nzikum from Yaoundé, Cameroon. I'm very interested on the report, which is something that governments always lean on for some important decisions. I'm very concerned about the fact that cardiovascular disease is like, the prevalence is higher like in 13 African countries in women than in men. Is there like some indication if I carry this report to my Minister of Health, like this is something which might be similar in Cameroon, because the countries in the low and middle income setting will have the same impact? Is there any reason? Because I wonder if the report brought out some risk factors which might be related to this disparity, which might be inequality in a way for women who are suffering, because the risk factors are always sometimes in a way of inequality. If I take, for example, air pollution, where I work in, those in low and middle income countries, women are more in kitchen cooking. This is one question.
Okay. I think we need to, we've got word to time, so.
Well, that's a very good point, of course, and the data is data. So basically you have here objective evidence of the data in different parts of the world. And you can use that, the data from your country, with your Ministry of Health or with the decision makers in your country to provide that sort of information and even compare it with some other countries, either in the region or some other places. The other thing is we also look at risk factors. And actually, if you look at the report for each country, you will have a little bit more detail by gender and by risk factor. So you will have that data. Of course, this is the first report. So the level of granularity that you will have, it will increase over time. And we hope to get more and more information that can more and more for each person or each organization in each region or country to use that. But for the moment, you already have quite a lot of information that may be helpful for you in your country to use it with your authorities, with your decision makers, that's for sure.
Thank you.
I'm sorry, we are at time now, so we have to bring it to a close, but thank you very much indeed for all your questions. And as I said, read it on the app. It's there, it's sobering reading, lots of statistics. But thank you to our panel for that great examination and highlights.
Thank you.